Okay, hi, welcome everybody to this webinar about antibiograms. We really hope that you find today's session useful. We would like to keep it informal, so we are going to open up for questions at the end, so after the presentation. So please wait for any questions until you're invited. But please do feel free to use the chat room and to keep your microphones on mute throughout the presentation. So this is a session that we at the CPA have put together in response to some feedback from some of the health partnerships around how to create an antibiogram. We're aware that there have been some challenges for some of the partnerships being able to do this. We're really keen to capture as much detail as possible about these barriers so that we can look at collaborative solutions, since at the moment some of these do go beyond the remit and scope of the CPA and CPAMS too. So please feel free to feedback these barriers in the chat, or also you can do that via email if you prefer to any of the CPA team. So we hope after this session that you might feel a bit more confident about being able to produce an antibiogram, but please do remember that this is not a mandatory element of the CWPAMS2 programme. So if you are facing challenges, we would much rather that you reached out and fed these back to us, rather than produce something that doesn't meet the quality standards that we're about to discuss. So with that, I'm going to hand over to Nyambura Moremi. She is a clinical microbiologist working with us here at the CPA, and she is now going to share her wisdom and insights into antibiogram creation. Thank you.
Thank you, Nikki. Welcome, everyone, to our session this afternoon. I believe it's almost afternoon everywhere. So I'm going to share the Antibiogram Insights, as Nikki rightly said. This has been a request from a number of partnerships. And today we are not going to create, but rather we are going to go through like the prerequisite for you to have a quality antibiogram. And maybe later on you'll see the needs. Depending on the needs, we can do another session on how to create, maybe on one-to-one. So this is the team, the microbiology team at the CPA. So we have Nikki here, we have Jean, we have Jem, and we have Claire. They are all on the call, and they'll be glad to contribute to this session and to answer your questions. So there have been some people have been using the word AST to connote antibiograms and vice versa. So this is well elaborated. Kindly mute. Thank you. So as I go along, I would like to declare that I've used most of the content from this CLSI guideline for those who are aware of the CLSI guideline. So the M39, but the 5th edition. So this guideline defined AST as a result generated from antibiotic susceptibility testing of a single isolate against a panel of antimicrobial agents. So when you have the AST of a certain isolate, AST profile, and you accumulate from different or a number of patients over a period of time, so that cumulative AST are the one that later on we refer to them as antibiogram, as we will see this shortly. So in case you fail to access that particular guideline, the 5th edition, the 39, because that is of 2022, you can access this particular publication from Zimner and colleagues. Actually, it talks about the upgrade that they have done of the information, because the 4th edition was from 2014. So close to 10 years, so they have updated this particular guideline on how to create antibiograms. So feel free to access that publication in case you cannot access the CLSI guideline. Why are we being bothered by the antibiograms? So these antibiograms, they tend to guide clinician on empirical decision. And this has been emphasized that we are creating antibiogram for us to be guided on empirical therapy. As you might be aware that patients sometimes come to the hospital very sick. You take the samples to the lab, but yeah, because of that severe sickness, you feel like that patient require antibiotics as you wait for the lab results. So in such a scenario, we have been offering empirical therapies, but most of the time, like blindly, just based on the knowledge, maybe this is neonatal sepsis, the most implicated organism with E. coli, maybe I should give more of the like the antibiotic to target gram-negative. So in such scenario, that's why we find the antibiograms useful, because these are the data that have been collected over a period of time from that particular specific area, from a specific disease and isolates. And sometimes this antibiogram also help us to track the trend of the resistance pattern that we are seeing at the local setting where we are. And these also tend to help us in tailoring our infection prevention control methods, as well as advocacy and awareness activities, especially for the AMS programs. They also tend to inform our antibiotic and hospital formularies also, as well as our prescribing habits. And for some of the hospitals, especially most private hospitals nowadays, those who are accredited under certain ISO standard, it is a requirement for them, for instance, to have antimicrobial stewardship programs. And within those antimicrobial programs are the one, like you find this, though, do you create antibiograms, how often and whatever. And even for us, I'm aware that most of the partnerships now like have the ASP programs and AMS programs, and that's why these like the issue of creating antibiogram have been like really a need, but they don't know like where to start. So we are here to brainstorm together. As you create antibiograms, yeah, remember I've said like you can see here on the top right, you have the AST profile against a certain isolate. If you accumulate this over a period of time, then you'll end up having like down here on my right, like the antibiogram. But let us remember that the outcome of a quality antibiogram still like is founded on the basics of the clinical microbiology. You cannot run away from them. So the quality of the procedure, the samples really matter for you to have quality AST profiles as well as quality antibiograms. So the pre-analytic, analytic, and post-analytic sessions, phases that we have like been singing all along our academia, our lab life, and whatever still stands. And here it's when also we observe like the essence of the teamwork from the clinical team to the laboratory team. So on the pre-analytic, for instance, the way you select your tests really matters. Like the way you select whom and when to test really matters depending on the working diagnosis. If you are suspecting a sepsis, like when to take the blood samples during the high peak of fever, if you can, like if you're suspecting infective endocarditis, what samples to take, maybe 2 different anatomical sites. So those things really matter. And this starts with the clinician who is seeing the patient. And in the lab, we really depend on the quality of sample taken. So those who are taking the samples, how do they prepare their patients for them to avoid giving us contaminants in the lab in case of blood, for instance, or urine samples? How do they choose the correct tubes to put their samples? How do they manage their specimen or their samples before sending them to the lab. Because sometimes we find people like taking urine samples, staying with them in the ward like 6 hours. And later on, even if you had the very little E. coli, which is non-significant, later on you'll find like it has been propagated every 30 minutes. So those are the things. But in the lab also, what method are you using to process your samples, like the standard operating procedures? How do you analyze? How do you ensure quality of each and every step that you are doing? How do you review your results? And how do you interpret and report those results to give you like the required AST? So as rightly said, garbage in, garbage out, quality really matters. I can feel the echo. Kindly mute for those who are not speaking. Thank you. So we want to quickly go through some pitfalls that we usually do when we create these antibiograms. One of them is, so you find like you have the results for the whole 1 year. For instance, you want to analyze isolates from urine samples. But you need to take into consideration of considering the data that will give you like statistical meaning. So the guideline, the CLSI guideline, the M39 recommends that we remove the duplicate isolates as we create our antibiogram for us to get a representation of the population that we are saving in that particular area, which is statistically sound. And this, it means that you find a situation where a patient, that particular patient, you see those patients, for instance, with the recurring urinary tract infection. So you have been seeing them like, maybe you can see a patient coming to the hospital, maybe 4, 5 times a year. So in those particular visits, maybe you took urine and maybe it was positive. So we need to filter those data to make sure that for that particular one patient, at least to get just the results of a single isolate to maximize the representation. Also, it is recommended to include clinically significant isolates rather than surveillance data, because surveillance data sometimes can overestimate the burden and don't really give you the right picture which you want to target the patient care. Another common pitfall, sometimes you find like people have created the antibiograms, but the isolates, for instance, they are less than 30. So again, this is going to be a bit not representative statistically as the way we wish to have this representation so that we can save all patients in that particular facility empirically. And it is recommended that if you might find yourself in a situation like you really need to analyze your 1 year data, but then maybe that particular isolate, for instance, E. coli isolate from urine is the one maybe is not, it's less than 30. So if you decide to use, maybe it is 25 or 28, then it is recommended you append a note below your antibiogram to show that the sample is not representative enough, so that the conclusion that you draw from that antibiogram, you should draw them cautiously. Again, this is another thing, the analysis frequency. So you find sometimes these bigger hospitals, they tend to have maybe a significant amount of samples, and they feel like maybe they should have their antibiograms quarterly. Yes, you can analyze, but be aware that you are going to miss the variations of the seasonality. Yeah, so that's why the recommended period is a year. So you collect yearly data to analyze for you to have a better picture, which capture also the season variation of those diseases and pathogens. Another important part that we overlook is data verification. So sometimes you find like there is a very beautiful antibiogram there, But looking at it, you find like you can clearly tell those data were not verified. And this is dangerous because at the end of the day, remember these data, the antibiogram we are generating are going to serve us as evidence for our empirical therapy whenever needed. So you find some mismatch, sometimes the bug drug mismatch. For instance, you might find Pseudomonas aeruginosa was isolated and ceftriaxone was tested against it. Or sometimes we find, for instance, the E. coli isolate is susceptible to gentamicin, but resistance to amikacin, which is unusual because we expect it to be more sensitive to genta. So also, in case of the surrogate antimicrobial agents, for instance, when you test, when you do cefoxtin test for Staph aureus to identify MRSA and MSSA, then you find like cefoxtin has been reported just the way it is. And instead, we really need to see, because that cefoxtin was a surrogate test for oxacillin. So we expect you to report oxacillin on your antibiogram. So these are just some very few examples, but I would like to emphasize that we go back to the basics, as I've said. There you can appreciate the M100, the CLSI guideline. This guideline has everything that you need. And you find like in most labs now, from my experience, most of the labs that they have well-documented procedures. But when it comes to doing it, sometimes I don't know if it is the overload or whatever, people don't take time to go back, or they don't put their job aid to aid their microbiological work. So you find like they have kept their antibiotic, for instance, these are for gram positive, these are for gram negative. So a person will just pull it from the fridge and starting like just putting out from the mind. So sometimes you end up having those mismatch. And unfortunately, if somebody is coming to analyze those data, like they go unnoticed, and you find like you have a poor quality antibiogram, which doesn't make sense. Another thing that we need to talk about is the choice of laboratory information management system and some analysis software. So here you can find that most of the LIS or the LIMS are not really tailored to bacteriology and mycology. And this has been a challenge. So sometimes you find even if it caters for that, sometimes it doesn't record the quantitative data, like the zone diameter. So Rose, kindly mute, thanks. So you find like you can have just the resistance susceptible and intermediate, so RSI. But the disadvantage of this, like you have collected that maybe those data for 1 or for 2 years, and you need to analyze your antibiogram. But in the middle of that, maybe the CLSI, or even if you're using maybe the UCAST guideline, they changed their breakpoints. So you might find like the interpretation you had is not the one that we are intending it now. And this can be dangerous to the patient care, because sometimes it can lead even to mortality if you give like the ineffective treatment. And there are other analysis software. For instance, for me, like I'm used to the WHONET, currently the WHO free software available. So you find some LIMS are very good, which you can interface, like you can extract the Excel sheet and just put on the WHONET. But some also, I understand, like they really need, you cannot interface, interoperate like that. So you need to enter the data again. Actually, this has been a very big setback to most of the places not like to enter data and generate the antibiogram. But from my experience, you find like these other analysis software, they make a bit life easier. So for instance, here I was just trying to put an example. If you go to WHONET, it gives you even that option of selecting just the first, like you select by patient and you select the first isolate only. So you just don't need to screen all. So it is screened for you and gives you what you want. So there are very good software out there, but you have to be keen, especially those which are not recording the quantitative data. Becomes really difficult later on to interpret, especially when the breakpoints change. But you find there are other software in a very good faith. Also the AMS program there, they tend to do what we call like selective reporting or cascade reporting, or even suppression. Like you tend to suppress, for instance, in case of gentamicin and amikacin. So if the isolate is sensitive to gentamicin, you find like you are not testing for amikacin, which is a good strategy to preserve those antibiotics, the broad spectrum. But then you have to remember when you start to analyze this data, because otherwise you are going to have biased number of isolates or results later on. Sometimes there are those selective reporting or cascade reporting. They report first, the first line. Then if the first line maybe doesn't work, then they give the option to the second line, which is also a good strategy to limit clinician not to use. Like if you give everything, clinician can prescribe anything. So, but we really need to remember those things to take into consideration so as not to have the biased data later on. Another thing is guideline mismatch. So you find like there are other places, sometimes you will need maybe to have the antibiogram from facility X, maybe with facility Y for you to have maybe a regional representation. But then you have to be sure like the guideline you use is the same, the standard operating procedures is the same, even because you might find the variation in breakpoints, which might give you a very different unintended data. So on top of those pitfalls, as we wind up, I need to remind you also of the important things that you need to see in that particular antibiogram, because they matter. The dates of the report, as we have said, like the recommended period is 1 year. So we really need to appreciate the dates that you have analyzed those data, like from January to December, maybe 2021. The facility name, of course, this will help us also the intervention in that particular local setting, because even sometimes these pathogens and their AST vary geographically. The organism and type of sample. So this is urine sample, and these are the organisms that have been isolated, and these are the AST profile, as we can see shortly. The number of isolates, because this also matter, it gives us the power to interpret those results, like the statistical power. Antimicrobial agent. Any comment on the methodology, as I've said, you can append there in case of any variation, but you still feel like maybe you need to analyze those data. You just put an appendix there. And the presentation of the percentage susceptible, if you have intrinsic resistance or the not tested sample. So this one you can present them either this way according to the guidelines. So some people present them this way. They put the R, then define maybe this is the intrinsic resistance. They put the NT to connote the not tested isolates. But so you can see these were the gram-negative organism from this example, and then you list every organism against the antimicrobial agent tested. So you can put that and define your, you have the key to define your mark, whatever mark you put within the antibiogram, or you can put the color code. I love the color coding, I have to declare. I find it easily to interpret rather than to put the numbers. But as I was reading the guideline, they have put a caution as well. Like you also need to consider some people are colorblind. So if you put the color codes, maybe you can accompany them with the shape. So that was just a point of suggestion, like an advice. So you can put and define the key. The percentage susceptible, I also need to emphasize this because this has been a question which is recurring. Really, for you to determine like what goes to green, like the one which you can give as empirical therapy confidently, the one which you might consider maybe the yellow, the one which you should not give, and the one maybe which you didn't test. This really relies on the antimicrobial stewardship team at your local settings, although the guidance gives some suggestion, like you can consider above 80 as green, like these are the one which you can consider to give. maybe below or equal to 60, you can put them as red, like not reasonable, but maybe 61 to 80%. This one you can consider to select, depending on the selective, depending on the situation at hand. So this is how you can present your antibiogram. Still you can tease out and make it more beautiful the way as you want, but make sure at least the key information are present as we have discussed. So by saying so, I believe you have grasped something about the prerequisite for quality antibiograms. And I want us to quickly go through a quiz here. You just look quickly based on what we have discussed, and you may wish to type on the chat box like what you think are the 3 pitfalls you can identify in the displayed antibiogram. So have that quiz as we prepare to go for the Q&A questions, where the team will be happy to discuss and answer all the questions that you have. So I'll be counting. Feel free to look at this antibiogram. Any pitfall that you can identify, just put it on a chat. We have 5 minutes. And there are also beautiful comments on the chat from other facilitators you can go through as you reply. I'm waiting to see the replies. Any 3 pitfalls, even one you can identify, just feel free to type in the chat box on the display that. Thank you. I can see people commenting. There's small number for the Klebsiella pneumoniae. Color coding is not, you have the key here. E. coli tested against ampicillin. Too few Klebsiella. 1 minute to go. Maybe then the discussion, I think, can start here. Ceftriaxone does not have data. Gentamicin entered twice. Okay, so we have the urine here, the specimen type, and these Staph aureus, E. coli, Klebsiella, and Klebsiella pneumoniae were all from urine, but you have Staph aureus as representative for gram-positive, and the rest are gram-negative. I think that's why here I find like it's open. It's the way they decided to present their data. No data for cefuroxime and Klebsiella. Nitrofurantoin tested for Klebsiella pneumoniae. Thank you. So I think we have captured some of them. Cefuroxime for Klebsiella, well done, everyone. Okay, colleagues. So yeah, we have picked some. I expected also people to pick regarding the data verification. I expected people to be suspicious of the Staph aureus number here. So can I imagine this is the urine sample, and Staph aureus is the most isolated strain. But if you go back to literature, I think this is a bit awkward. So for me, I suspect more here, there is a problem here. 129 isolated, as you can see, others. E. coli 127 is fine. Klebsiella, but Staph aureus like the leading cause of UTI in this particular setting. So I don't know here, there are a lot of things to query, even how they instruct these patients to take their urine samples. Regarding the missing data, most people have commented on the missing data. Now, this is the challenge that we are facing. We'll be happy to hear from your setting as well. But I think in most like African settings have managed to be, you find like there is this interrupted supplies of these reagents and consumables, including the antibiotic disc. So today you have them, tomorrow you don't have, so you test what you have, test against the available ones, then tomorrow you have it again. So those have been a challenge. And also, I also expected people to pick, I saw somewhere the cefoxtin, yeah. So you have cefoxtin here. Remember, we have said those surrogate tests, it's better to put now the really, which should be reflected like oxacillin here. No data for Klebsiella pneumoniae and tetracycline. So there's a question that have been asked about nitrofurantoin being tested against Staph aureus, as well as I remember which one, and Klebsiella pneumoniae. So I would like to welcome now my co-facilitators, especially Dr. Jean, to start the discussion. So if you have also any other question, I think this is the time. Also, Reniki, I'm taking your position as a chair. Thank you very much. So, Jane, would you want to comment on the nitrofurantoin being tested against Klebsiella pneumoniae and Staph aureus?
Yeah, I think they probably are. It's not a great antibiotic really against those organisms. And yeah, as you say, it's a bit odd that the Staph aureus is the leading cause of UTI, it appears, and also that it seems to be MRSA as well, because at least about 2/3 of the strains are resistant to cefoxitin, which makes it an MRSA. So there's whether there was an outbreak maybe in the setting or something. You'd like to have more information about it. I mean, obviously nitrofurantoin is a useful antibiotic for sort of empirical treatment of UTIs generally, but you have to be careful. And obviously Proteus is intrinsically resistant to nitrofurantoin as well.
Mm-hmm. Thank you very much. And Klebsiella pneumoniae is intrinsically resistant to ampicillin. This was a comment. But I think, I don't know about the UCAST guideline. The CLSI guidelines still recommend to test ampicillin against most gram-negatives.
I suppose if it is active, then it's a useful, narrow spectrum antibiotic.
Mm-hmm.
But it's very unusual in this day and age, really, in most settings for things to be sensitive to it.
Yeah, and most of the time you find like it is resistant.
Mm-hmm.
It is not of value anyway.
The other thing I suppose is interesting about whether some of those antibiotics would be active in UTIs like clindamycin. I'm not sure if that's used. It's obviously fine for Staph aureus and soft tissue infections and other Staph aureus infections, but I don't think I'd ever use clindamycin because of its low concentration in urine.
Yes, so you are pointing out to a very another pitfall. So if you go even to the M100 as a guideline, the CLSI, I know in the UK you use most of the UCAST guideline, but this has been like stipulated very well. So it's the habit that I'm saying, like you find the lab keeps the antibiotic drugs for gram-positive and gram-negative, and they just pull and test. So if you go back to the guideline, you find like it is clearly like indicated for skin and soft tissue infection and not urine. But because somebody has just pulled the container for these antimicrobial, what do I say? the antimicrobial disc to test again. So it just tests. So that's another thing that we are seeing. And so this is what we usually give to patients. So this is a very, like, it's not fabricated. This is a really antibiogram from a facility X that I've decided to blind. This was their 1 year antibiogram, but here I didn't label it. I expected also people to pick that this is even not labeled. So over to you, Nikki, to moderate the Q&A sessions. Thank you very much.
Thank you so much. If anyone has any questions that they would like to ask, please feel free to raise your hand or jump in. I think, Claire, you had one in the chat.
Yeah, I think Niambura and Jean have kind of answered this actually, but my question was around, if reagents are short, does it make more sense to kind of limit those to the likely organism and source? So I think that was my query around the nitrofurantoin for the Staph aureus in the urine, but also I think somebody else picked up the clindamycin gene as well. So yeah, if you're not going to use an antibiotic, what's the point in kind of testing it almost if it's not going to get to the site of action? I don't know what other people's experiences are actually of antibiotics being tested and having the results of those.
Yeah, so for like if I might comment on this, the antibiogram I've just shared for the quiz. Like in Tanzania where I work, we revised we call the National Standard Treatment Guideline, and you find like the first line actually for UTI, the first line is nitrofurantoin. They changed it from ciprofloxacin and back then because of the evidence that they generated from clinical perspective, although they also included a bit of research. So they came to, so that's why you see, I think that nitrofurantoin was tested, because still it is regarded as a first line for UTI, especially outpatient UTI. Regarding the shortage of the reagents, it's sometimes it's not short because of the like the funding. So sometimes you just find like you procure, but sometimes it takes too long, the procurement process, especially in public facilities. So later on you go like those antibiotic missing. But also there have been a question now that has been more raised. You find like the lab tests the isolate against antibiotic, which you cannot find in the like hospital pharmacy or the nearby pharmacy. So at the end of the day, it becomes a waste, because you do, this is what you are saying, Claire. So you test against clindamycin, for instance, while you know you cannot offer clindamycin for UTI. So that's why I think it is still most recommended, and I think we should try. The challenge is nowadays we have the lab scientists. The microbiologists are not really working in the lab. Most of them are working in the university and research institutions. But we really need to go back to the basics of microbiology, and to keep like reminding ourselves in CMEs and whatever to be on the track.
Great, thank you. I think we have a question. Babatunde, would you like to take the floor?
Yeah, good afternoon, and thanks for this session. Apologies, I was in another meeting and joined a bit late. So we've been trying to come up with an antibiogram at my center. I work at the University College Hospital, Ibadan. But we have not been able to gather isolates up to 30 over 2 years period. I mean, ideally it should be over a year, but we combine 2 years, which is also allowed, but we don't have up to 30 isolates. So what would be your advice? I see that you also have quite impressive isolates from urine alone. I mean, and these isolates I'm talking about from all cultures that come into our lab. So that's a big challenge for us. How would you advise you go about developing our antibiogram, please? Hello?
Oh, yeah, thank you very much. I didn't pick your name, sorry, but I think I've heard the question and the challenge. I'll go first, then my colleagues will contribute. So the issue is when you have the limited number of sample of isolates, it becomes challenging. Like you might overstate the problem, which is maybe not to that extent. And the recommended period is 1 year, but sometimes you can even have your antibiogram for a period of 2 years. So I don't know in your case if you can try maybe to pull even the 2 years, because that's the minimum. But I think you can go to 2 years if there is that particular challenge. And I don't know like how little, because less than 30 can mean even 5 or 10. So I don't know like how little, if you can maybe elaborate. And is it for all like the necessary, for instance, the recommended samples like blood, urine?
So we actually have tried to pull over 2 years, and even at that, we're struggling. We're struggling particularly for organisms like Pseudomonas, Acinetobacter baumannii. For Klebsiella E. coli staph, fairly enough sample, but even at that, and these are samples from, these are isolates from all samples combined, from blood, from urine, from tissues, all of them combined. For Klebsiella pneumo E. coli, we're not getting up to 30, maybe like 20 something for over 2 year period. Yes, maybe there were some downtimes in the lab when there was a strike or something, or they had issues with reagents. But the point is now we've combined data from 2 years and we still don't have up to 30 for some isolates. For some isolates like the Pseudomonas and Acinetobacter, like I mentioned, they're really less than 15 for the whole 2 years, some less than 10 for the whole 2 years. And these are from all sites, from blood, from urine, from all sites.
Oh, thank you very much. So I hear your frustration, but I think you are raising another very good point. Maybe we didn't talk about. I don't know if I can go back with this presentation. Let me check. So I want to talk about combining also the isolates from different samples. That is maybe another common mistakes that we are doing, which might affect the real picture. So I want us to appreciate this antibiogram. That's why I was trying to go back. This is also a real one. It's not like fabricated from facility X. Actually, this is a representation, the national representation of somewhere. So if you see here, if you try to see, these are organisms from urine, and here we have organisms from blood. So if we try to follow, for instance, E. coli, yeah, E. coli from urine, if you try to follow that first row and try to follow the E. coli from blood, definitely you'll see that they behave differently. So also combining, that's why we need like isolates from certain species, maybe preferably from the very same sample. So for you to know that in our setting, if we have sepsemia and we isolate, for instance, E. coli, this is the most likely AST profile that you can get. So as you wait for lab results, you start the patient on that particular profile. But if you combine these isolates in analysis, you are more likely to get a different picture. So I don't know about the experience from other places. Jean, maybe you can comment. Combining isolates from different samples.
Yeah, I suppose it's balance between, as you say, you know, not overstating resistance if you're using too few isolates, and yet, you know, trying to get the sort of granularity of detail from different sites, maybe giving different sensitivity patterns. I think you could probably combine coliforms, you know, as a sort of general collection of bacteria. If you really have only got maybe 20 or 30, you could maybe combine E. coli and Klebsiella, even though it's not great to do that all the time. But sometimes you can sort of group bacteria together, and I think Pseudomonas obviously has to stand alone, but I think sometimes even having just a few strains of Pseudomonas, it's worth giving, you know, putting those, even if you've only 20, say, over a year, reporting those and then having an asterisk saying, obviously, there are few isolates and, you know, the results should be interpreted with caution. But I think knowing that maybe there's a tendency in your Pseudomonas isolates to be being very resistant, that's really important to know. So you might have, you know, Pseudomonas strains that are resistant to meropenem. So I think it's important to report those, and even if there are few isolates, you know, it's something to be keeping an eye on. So I think, and Acinetobacter, again, these are likely to be very resistant. So even if you've only got maybe 20 or 10 isolates, if they're all resistant to meropenem, that's really important to know, because, you know, that gives you a sort of a flavor for what you're worried about and maybe having to test different antibiotics.
Great insights. Appreciate that. That brings me to my next question, if you don't mind, please. And good thing you brought up this, that's from a national aggregate, the one you just showed just now. How much value would that bring to clinical care, considering that you have isolates from different hospitals and probably different demographics and behavioral patterns with antibiotic use?
Thank you very much for a very nice question. So that's why for the patient care, this was more of aggregating data, I think reporting to them to GLAS as a surveillance from those sentinel sites. This one might not display a true picture from the facility. So maybe, as you're saying, you joined late, but we recommend the antibiogram for decision-making for patient care. And for patient care also, not like the routine. This one I would like really to insist, because it's not a substitute for guided therapy from the lab, but we are giving these just as evidence-based empirical therapy whenever needed as we wait for lab results. This one I really need to insist, because even most guidelines also insist. So you are right that the aggregates won't give you a true picture for patient care, but rather the facility-based antibiogram. So these were aggregates. That's why you see like there are a lot of numbers there. But I believe before this, they do have the facility ones. just as the one I've just shared for the quiz. Those one can guide the patient care for the facility as we wait for lab results.
Thank you so much.
Thanks. We have a question in the chat box. So as far as the aim is reducing the antimicrobial agent's resistance, would there be any supporting methodology where the ordered culture and sensitivity may be done? Mpoki, would you like to expand on your question if you're still with us?
Okay.
Thank you.
As our facilitator of this at a certain site, but the challenge is in most cases, some doctors may order maybe culture sensitivity, but according to levels of facilities, maybe in Tanzania, there are some facilities where they don't have the culture and sensitivity materials. And even if they are having, sometimes they may lack other supportive things which may help them in reaching their investigations. Hence, that's why sometimes it ends that people are just following the STGs on prescribing drugs.
Okay.
Mpoki, are you done with your question? Because I think I didn't get your question. Sorry. If you can repeat and summarize.
Okay, let me repeat.
I see here as culture and sensitivity really being done most. I think you meant to write ciprofloxacin mostly being used as far as its UTI. I don't
No,
get
what
it.
I meant is
Mm.
what I meant is that in most cases, as far as the people are following SDGs, so on treating clients, but rarely culture sensitivity is being done. So being as we are having few sites which are doing this antimicrobial and microbial stewardships involvement, how will they be supported that they may, so that the doctors may prescribe the drug according to what may be sensitive to that pathogen causing the disease? That's it.
Okay. So thank you. I see Jen was trying to also respond there. Yes, an antibiogram should help predict what can be used. Yes, in most settings, as you rightly give the example here in Tanzania, for instance, culture and sensitivity is being done up to the regional referral hospital levels. So from district downwards, really, there are no culture and sensitivity facilities, especially for bacteriology and mycology. They really rely on the standard treatment guideline. But as I said earlier, for instance, for the UTI, regardless of the cause, as you might see, people other colleagues have commented on the nitrofurantoin being used against, for instance, staph. The effectiveness is low compared to when being used by UTI. And you find even the standard treatment guideline, the STGs, tend to go by kind of majority supported by evidence. So like common cause of UTI, then maybe that's why they put the nitrofurantoin as a first line. But as Jean said, like antibiograms such as this might help. But now for them, they might benefit, although it might be not a true picture, but from the aggregated antibiogram, because they don't have the data on the sites, and all they have is STG, and you find like the standard treatment guidelines sometimes are being reviewed after maybe 3 or 4 or 5 years. Based on the accumulated evidence. So meanwhile, the antibiogram we are generating, as you can recall, we said like it helps us detect the pattern of resistance. And by the way, here, I also need to stress one point I've remembered. You find like in some places, they generate those antibiograms just as the table, as we are seeing here, this summary, and give it to the antimicrobial stewardship teams for them to use. We need to write a report. Like you really need to write a report about it, at least summarize the very key findings, compare, you can compare. If this is not the first antibiogram you are generating, you can compare maybe the one you developed like 3 years back, analyze the trend. So pick the key points and give them like a brief but detailed summary for them to make decision on IPC program and other intervention to curb AMR. So yes, in those settings, we can use antibiograms as well as standard treatment guidelines to treat them empirically, because we have no option, because we don't have the facilities to do catch and sensitivity. Any addition?
Thank you so much, Nyambura. I think we're going to have to stop there because we're at time. But we at the CPA, we've been considering a sort of email-based community of practice for people to join so that we can all get together and share our experiences and troubleshoot like these problems between us as a community. So what we'll do after this is follow up via email, and if everyone would like to be part of that, we can get that set up. But just to reiterate as well, please feel free to reach out to any of the team, the CPA team that are on the call with any concerns or questions you have about this or any of the other technical aspects of the programme. But with that, I'd just like to say thank you again to Nyambura and to Jean, Claire and Jem, who are also supporting. And thanks to all of you for attending. Hopefully we'll see you again soon.